Biochemistry, KIMS Medical College and Hospital, Bhubaneswar. I extend a warm welcome to all our panelists and our dear moderator, ma'am. I request her to begin the session. As you please.
Thank you. I would like to first thank the association for keeping this topic, which is very close to our heart. It is not just a problem of the women, but the entire family is affected. That's why it is a topic that should be discussed among all the middle-aged people, I guess. So, the theme, perimenopausal health and unaddressed envelope. Why it is so? Because in perimenopausal age, since morning we have been listening to these things, that there are so many different kinds of problems related to different organ systems, starting from easy fatigability to mood swings to even committing suicide, backache, water retention, whatnot. So during this perimenopausal age, actually we never know whom to go to, whom should we approach so that our problem is really solved. In fact, at times we do not even realize that we are having a problem. So that is another thing. So we need to create some awareness. This menopause or perimenopause. Let me come to a little bit of our scriptures. We have 4 ashrama dharmas, like Brahmacharya, then Grihastha ashram, Vanaprastha and Sannyasa. So every phase is having an intermediary twilight zone. Like we cannot jump directly from day to night, night to day, we have a twilight zone. Likewise, this switching from Grihasthashram to the active reproductive age group to menopausal age, that is our Vanaprastha, we have a perimenopausal age, and that is also not specific, that is highly fluctuating, and it is having so many associated problems. How to ease this bugging phase of our life when we are really struggling with so many other things as well? This is kind of our sandwich phase of life. We have to take care of our elderly parents, we have to take care of kids, growing kids. Amidst that, we have to take care of the health of the woman of the family. So, with this background, let us start certain questions. And since this is, a problem particularly mostly coming to either endocrinology or gynecology, mostly gynecologist. So my first question will be, ma'am, Sandhya ma'am, we have been discussing the different stages of perimenopause, and it can extend from a very young age up to 51 is average age for menopause, actually menopause in US, but in Indian population I think it is 47. So in your clinical practice, what is the earliest age you have faced where a lady has attained menopause?
Earliest age at which menopause happens means if we consider premature ovarian failure, it will be in the early 30s. Like suppose it is less than 35, it will be premature ovarian failure or premature ovarian insufficiency. Otherwise, if it is around like 40, 45 to 47 is the average age for India, then it is early 40s. early 40s. I have seen menopausal women at 35, 34, 35 I have seen.
So that's quite early.
In that regard, even I can say, when the irregular menstruation starts, like someone few days ago, woman has come with irregular periods. When I asked, I was thinking she is going probably to tell me her age is around 38, but she was 28. The irregularity of the menstruation can start in late 20s as well. Because the perimenopausal transition can be not limited to 4 to 5 years, but it can be more than 10 years. Definitely it is 12 years which I have experienced personally, but many people do experience the perimenopausal transition to be more than 10 years.
Okay, thank you, ma'am. Ravi sir, exactly which event in our life triggers this process? What really happens? Is it just aging or somewhere else, the genetic molecular factor or any particular hormonal factor disruption? What really triggers this beginning of all these processes?
Actually, menopause, like we understand, is a very slow process. It is not that suddenly somebody will become menopause, except in cases where somebody is receiving chemotherapy, somebody surgically ovaries have been removed. In such, except those cases, natural menopause actually takes a transition period. So your question is, what exactly triggers this menopause? Actually, what is happening is that we have got at the birth, roughly we have got 1 million primordial follicles, which go on decreasing in the age of puberty and in the age of menopause. So there needs to be a critical decrease in the follicles number to decrease the estrogen level so low that it is difficult to maintain the normal menstrual cycle. So in other words, normally what happens is that by puberty we have got, say suppose, around 50,000 follicles, and by the it has been estimated by the age of 30 years, they are only 12%, by the age of 40 years, it is only 3%, and by the age of menarche, it is only 1,000 follicles are there. I think somebody has shown in this slide in the morning itself. So it all depends upon how quickly or how slowly the follicle number decreases to a critical. Now your question is also regarding various factors which might influence this process.
That also.
Yes. So some of the genetic factors like especially GDF9, especially more morphogenetic factor like 15, these play a vital role in shaping thereafter a premature ovarian failure, or it may lead to normal maturation and normal timing. Of course, as in the morning also there was some discussion, various lifestyle measures or various life factors also influence the menopause. For example, somebody who is obese, so it takes the menopause happens a bit later. Somebody who is smoking, it happens a bit earlier. So somebody who is ethnicity, some people may have early, like African Americans. So it depends upon, one is race, ethnicity, genetic factors. So I can't say that only one factor will be responsible for this. A host of factors over a period of time affecting the follicular count, starting from the menopausal transition, ending up with the final menstrual period.
So does stress affect onset of menopause?
It has been seen that stress doesn't actually affect that. It has not been found to be in studies that actually stress affects the menopause early. But of course the parity and some other factors like nulliparity has been found that it occurs early. So stress as such, it has not been validated to cause menopause early or later.
Thank you. Ma'am, Prakruti ma'am, can you tell me what is the relationship of HPA axis with menopause?
Thank you for the question. I need to clarify this hypothalamus pituitary adrenal axis you mean first. So, as we know that the cortisol level, it has been found to actually increase. Around the perimenopausal time, research can validate more. But there are many theories attached to that, like the HPG axis is already not functioning properly, and we know that the estrogen and the progesterone level goes down, and that will finally it comes down. But regarding this cortisol rise, there has been a cortisol rise, but studies do not correlate it with the stress that is associated with the perimenopausal time or the menopause. But the cortisol rise is maybe due to that the estrogen also has a negative feedback on the HPA axis, which has been shown. So if the cortisol is rising, maybe it is related to the estrogen fluctuations which is happening in the perimenopausal period and the menstrual.
Can stress in our life be a confounding factor in this? Because this is the most stressful phase in life. We are after our kids, and we are also having.
But actually, as Sarah said, one of the SWAN studies, like the United States have done the SWAN studies, so they do not have found that the stress and this cortisol level is actually related. The rise in cortisol level. So maybe, as Sarah said, it has not been validated that the stress is actually leading to the rise in cortisol level, and or that cortisol level is related is an effect of the stress, which is doing this. So maybe it is the estradiol fluctuation and the FSH and LHS fluctuations which is actually having the effect on the axis.
Okay, thank you, ma'am. So very frequently we see obesity associated during this stage, and really women are struggling to, maybe due to associated factor, again maybe our sedentary lifestyle or stressful lifestyle. But one thing is that definitely there is some obesity we find at this age range, and maybe after that it declines and people keep good health. But there is definitely little bit truncal obesity and kind of as if the lower abdomen hangs out, the visceroptosis kind of obesity is seen in perimenopausal women. So can you please enlighten us regarding this pattern of obesity that is found in perimenopausal age?
Thank you, ma'am, for the question. So, when the third phase of life starts, I think Vanaprastha, things start shifting, peripheral to central, basically. Now, estrogen is not just a feel-good sex hormone. We have to come to that terms with it. Estrogen is responsible for the peripheral deposition of fat in the female species. What is mainly restricted to the gluteal region and to the femoral region during the perimenopausal period makes its way towards the trunk, and that is central visceral obesity, which is one of the cardinal features, again, if we recall syndrome X or metabolic syndrome. And this particular impact actually results in a lot of dynamism, because adipose tissue, we have to remember, it is a very dynamic kind of tissue. It is a metabolically, or rather I should say, an endocrinally active tissue. And during the perimenopausal period, if there is associated obesity in the lady, then there are always chances of upset of the milieu of leptin and adiponectin. That also one has to take into account. Leptin, if becomes low, we all, I think most of us are aware, that raises the, I'll clarify. It raises the appetite. And there is voracious feeding, and that again contributes to the vicious cycle of further obesity. And adiponectin levels, strangely enough, are low in the obese women, whereas the leptin levels are high. But it's a futile thing. Even if they are high, that comes later on. Initially, low leptin levels stimulate a high rise of appetite, leading to obesity, after which, even if the leptin levels remain high in the adipose tissue, it is of no use. And adiponectin is responsible for greater insulin sensitivity. And in obese women, particularly in the perimenopausal age group, that leads to insulin resistance. The other thing is, with insulin resistance, there will be concomitant rise of gluconeogenesis, there will be rise of blood glucose level, and type 2 DM will come with the insulin resistance. Moreover, the adipose tissue is very richly supplied by portal circulation also. So there is a connection, if once we are thinking of portal circulation, there is a connection between adipose tissue and the liver. So again, hepatic lipogenesis, production of VLDL cholesterol becomes very high. And from VLDL you get LDL, and the total cholesterol to HDL cholesterol ratio, that also increases. So in summation, what happens is all this, again the root cause is again a low level of estrogen. And there is one more thing which happens, there is peripheral aromatization of androgens to estrogens. That also contributes, not estradiol but estrogens. There is one more factor which comes here, obesity, which predisposes to loss of inhibin B function. Now this inhibin B comes actually from the granulosa cells of the antral follicles, and inhibin B has a negative impact upon FSH action. So that action is lost. So what happens, there is too much secretion of FSH during this period, and that stimulates more of estradiol function, which is again futile, and this estradiol, this persists so long as menopause actually doesn't set in. But during this time, the estradiol causes instead of alleviating some of the better symptoms like bone density or lowering the lipid level, what it does is, these estradiols, which are futile estradiols, they end up stimulating the endometrium. And that leads to endometrial hyperplasia, dysplasia, and even increased chances of endometrial cancer. And of course, when there is more estrogen, once the menopause actually sets in, that leads to a more chances of developing breast cancer, which are ER/PR positive. So basically, if there is obesity, it leads to higher levels of estrogens and more chances of metabolic disorders. And in the nutshell, when the menopause sets in early, oddly enough, the estradiol levels, they start increasing, and that leads to increased chances of developing the malignancies. But during the perimenopausal period, again, since the estradiol functional level is low, it again leads to lower bone density and chances of cardiovascular complications. So the best way out is that before the perimenopausal period, because now there is a very important term now I was reading, it is called MT. Menopausal transition. I don't know how much we are aware of this, but this is the time period they say, maybe our gynecologists over here, they are aware of it. I was reading about this. This is called menopausal transition. This is the time period from the last menstrual period up to actual setting of menopause. And it is during this window period that most of these physiological changes are occurring. So, and that is more common, it's faster, it is earlier in obese women. So if you want to negate that, then the better thing is to get rid of obesity before this time period starts.
Yeah. Otherwise it is very difficult to get rid of obesity as well.
No, it's very difficult to get rid of obesity. We are all struggling with that.
Because
it's a vicious cycle again. So now they are not advocating hormone replacement therapy. In fact, now we don't even call it HRT, they call it MRT. Menopausal hormone MHT, menopausal hormonal therapy they call it. So they are not advocating estrogens.
Yeah.
So no longer the easy solution. Why? Because if you give estrogens from outside, the chances of those malignancies which I said, those are increasing. So they are saying you go through the hard way, diet and lifestyle modification, exercise.
Thank you, madam. You have explained so well. Now another talking, but vague, and it is not usually complained by many women, that is water retention. Sir, can you explain what is the mechanism of action? Why we get water retention very frequently during this perimenopausal age?
Yes, if we need to, first of all, thank you for the question, and this is my first visit to Brahmapur. My heartfelt gratitude to all the organizers for this wonderful hospitality. Coming to the question proper, if we need to understand the part of water retention, we need to first of all discuss how estrogen works at the cellular level, and what are the implications of those cellular interactions. So, as far as I know, the cellular estrogen works in the cellular level in 6 fashions. 6 pathways have been described. Obviously, it works through the estrogen receptors, which are of 2 types, as we all know, cytosolic receptors and the transmembrane receptors. The first two pathways involve the cytosolic receptors. In the first the estrogen binds to the receptor, internalizes to the nucleus, and then after dimerization of this ligand, they bind to the ERE or the estrogen response element on the DNA, and thereby start the transcription. The other process involves certain transcription factors. For example, C-phos and C-joule. They form a ternary complex and then enter the nucleus. These are the two main pathways. The other pathways do not involve the cytosolic receptor but involve the transmembrane receptors, wherein they trigger a kinase cascade, most specifically the MAP kinase and the ER kinase cascade, and then they form the ternary complexes with those transcription factors, and then bind to a separate promoter region other than the estrogen receptor response element, and then initiate the transcription process. Furthermore, what happens after these transcriptions take place is the various proteins which actually form the other downstream actions. For example, these are specific to different organs in system. For example, as elaborated by Sarmishtha, it involves in the endoplasmic endothelial hyperplasia in the uterus. Then in some other cases, for example, in the bones, it involves in the down depletion of the osteoclasts, thereby decreasing the resorption of the bone. Then finally, in the vasomotor area, they involve in the various pathways are involved. One of those is the internalization of the LDL receptors, thereby decreasing the LDL uptake by the endothelial cells. This is important in the coronary artery occlusion, etc. And this is how it acts in various pathways throughout the body. And furthermore, to alleviate these things, what is now is advocated is that HRT should combine estrogen and progesterone, because progesterone has antagonistic action to some of these effects of the estrogen.
Thank you, sir. One question for Dr. Vibhu Kalyan. Sir, we have discussed about the mood swings, the different psychological impact. So, actually, even the mood swings can go up to suicide also. So, have you ever encountered such a patient who was vague in describing herself and finally landed in this? Or what is the real cause of irritation? Why they are mood irritated? Whether it is psychological or organic, actually the depression is why the patient is so much depressed.
Thank you, madam. Thank you for the question. Now, first of all, we should understand what suicide is. Now, if we look into suicide, first of all, one begs depression, pride is there. Now, the three things: a person who is who has lost hope from himself, from the surrounding and the future. Everywhere negative things are coming up. Now, if we look into depression also, the cardinal features, among them the biological features which are there, like sleep, appetite and libido, automatically because of the hormonal influence, those things are already deranged in a perimenopausal woman. Adding on to it, the psychosocial milieu, if you see, there is this emptiness syndrome. A woman wants to look good, but because of all this frontal obesity and all that, maybe she is having a problem on an infinity context. Yes. Along with that, as Indra madam was saying, the ornaments of a woman is the ovum, and the ovum, the ornaments have lost their luster. So that again is adding on to symptoms like schizophrenia, where commanding hallucinations are also possible. Now, if we look into suicide per se, it's just an impulsive act. A person, when he doesn't find any other option to come out of his problem or her problem, at that time he thinks of doing that. So yes, we have seen many cases, those who have already committed, of course there is no chance that we can inquire anything about it. As my senior bhai has already said, that 1 in 10 are having suicidal ideation. In fact, suicide itself has multiple phases. Death wishes, suicidal idea, then comes suicidal attempt, and then committing suicide. So we get such cases because involutional melancholia is such a thing. It occurs both in female and male, but in female the age group is again between 40 to 55. And multiple familial risk factors are also there. And also I will say there is some temporal relationship with this perimenopause, because this has-bahu conflict, which is very common. Now I will say maybe this has is having the perimenopausal syndrome. That is why she is a bit irritated, and that is why probably she is not able to deal with the bohu or the daughter-in-law properly. So adding up all these things, anywhere like in any psychiatric condition, a biopsychosocial model, of course patient can go up to suicide.
Sir, any chemical changes or particular any factors are rising? If you have encountered who has attempted but or any case studies you have encountered?
Till now, whatever we have information, actually in a clinical setting, directly research-oriented work is not possible always. But what exactly we have, as per the data we have, the cholesterol level is low in suicidal patients, number one. Number two is, yes, this gaze, this monoamines are bit less. But again, there is another theory. If there is deep depression, in that case also, a person doesn't want to commit a suicide, because that is again one act. So initially when we give some antidepressants, like we all were talking about SSRI, SNRI, so initially we also add on something like benzodiazepines, that is for action of the SSRI. Along with that, at least it will act upon the GABA, so that at least those activities like committing suicide will also come down. Because
sir, how can someone know that actually she is depressed, feeling depressed or irritated, and she should go and talk to some actual qualified doctor, not just to friends or anybody?
This is very important, because this is the reason few years back we had a theme for the WHO World Health Day, that is depression, let us talk. Because depression, there are two only cardinal symptoms. Number one, feeling depressed and lack of interest in pleasurable activities. Now, if anyone is having that, then ideally they should talk to the others, talk to the colleagues or talk to the family members. Even the Government of India has already set 52 or 53 centers, one of them where I am the head of that is Telemanas Center, 14416. That's a common number. From anywhere you will call 14416. Regularly counselors 24/7 are sitting. They will answer you, they will directly talk, and they will guide you that where you should go and what to do. And if someone is in doubt that whether I am depressed or not, then
some awareness should be created among this group of women that if you don't feel okay, you just go and talk to a doctor or call somebody, some qualified person, right? Ma'am, you must be encountering many patients at this perimenopausal age with menorrhagia. Probably that must be the most frequently you are encountering out of all the symptoms. Because for easy fatigability or this or that, they won't come. Or backache, for that they might not be coming you and approaching you. But menorrhagia is definitely very bugging, right? So,
actually the menopausal transition, how the normal menopause or menstruation should proceed as we age, is gradually the cycle should be lengthened, the amount of bleeding should be reduced. That is the normal thing. But what we encounter in clinical practice is mostly heavy menstrual bleeding as well as shortened cycles. The shortened cycles do happen, but as the menopause approaches, again the cycle length will be increasing and increasing. So during that perimenopausal transition or early menopausal transition, the cycle length may reduce. In a normal menstruating woman, the initial cycles are, the interval is longer. At 20 to, I can say 20 to 30 or 34, 35 it is given. The cycles will be at 28, 24 to 28, and gradually the cycle again should become oligomenorrhagic, means cycle interval should increase. But when there is there is pathology affecting at that perimenopausal phase, again at the perimenopausal phase we encounter a number of abnormal uterine bleeding of organic etiologies. So if the cycles are shorter interval and there is heavy menstrual bleeding, it definitely indicates to evaluate on the causes of abnormal uterine bleeding. And otherwise it is should be less in the menopausal phase. Apart from menstruation, also we come across when the more nagging symptom of menopause or perimenopausal phase is, in addition to water retention, what Madam has told, frequency of micturition is again a very troublesome symptom of the women, what they encounter. It is altogether adding to the genital changes that happened in the process of childbearing, and which gets precipitated with declining estrogen level. So frequency of micturition is definitely a problem. And what you told that backache, people are not probably presenting to us with backache, but they really present with backache, again a sign of some amount of bone mineral density decline, and also they come with sciatica type of pain. And when they have added endocrinological abnormality, especially diabetes mellitus, we may be thinking it is diabetes neuropathy, but it could be also because of the decrease in the BMD, and there is compression or postural effect. So some type of musculoskeletal pain also they are presenting to us as.
Thank you, ma'am. So now that we have listened to so many symptoms and signs, so now coming to our diagnostics part. So I feel that should be a metabolic profile, a panel of tests for this perimenopausal problems, right? So if somebody comes to us, any of the clinicians at 35 plus, with any of the symptoms at least, we should be suggesting them to go for a metabolic panel or test panel for perimenopause, isn't it, ma'am? So what should be included under that panel?
So thank you so much for the question. So first we should thank you so much for the question. So we should first identify whether the patient is really having a pheromone increase in the perimenopausal stage or not. So how can we assess that? So when we estimate the FSH level and it is persistently more than 30 IU per liter, then we come to know that it is perimenopause, and if he or she has attained menopause, then it will be persistently more than 40 IU per liter at a consecutive 2 times at an interval of 6 weeks. So now if you tell me a patient who is in the transition phase, suppose we have to then go for the FSH, then we go for the hormones, estrogen. We know that the estrogen level will be fluctuating and it will be having all the symptoms of the perimenopausal symptoms. So we can go for the estradiol 2, E1, E2 and E3, especially we go for the E2. Then we go for the progesterone levels, these two will be low. And then we can go for the testosterone level, which will be very high. We can go for the DHEA and DHEA-S, we can go for that also. And then we can go for the androstenedione. Then we can go for the, as we were talking about the stress, cortisol level and the
How to how much SHBG will help?
Yes.
SHBG?
Yes, sex hormone binding protein, that also will help. Then cortisol level will ultimately give us a idea that if it will be increased, the inflammation will be there, then the testosterone will also increase, which will ultimately there will be insulin resistance also because of this pre-metabolic cortisol level. And then we can estimate there is a test for cortisol awakening response stress test. It will actually assess the HPA axis, and we can go for the melatonin level also. So these will all decide us where we are in the menopause or in the perimenopause. Now coming to the metabolic profile, because we know so many things. First, insulin, she was talking about obesity. So insulin resistance comes. So we can go for the fasting glucose, and we can go for the fasting insulin, we can go for the HOMA-IR. So with that, we can come to know whether the patient is having insulin resistance or will lead to diabetes or is in the diabetic stage already. Then we can go for the lipid profile, that is customary. We have to go for all the profile where we see the ratios of the total cholesterol with the HDL. We should go for the free cholesterol, cortisol level, then prolactin, thyroid hormones. We should not forget that we have to put into it. And
I think this iron profiling
yes,
also.
yes, iron and PCPC we will do once we get the hemoglobin is low. We have to go for the whole iron profile. Why it is
And
so
vitamin D.
yes, vitamin D, and we can go for some oxidative stress test. That is actually an advanced one.
Yeah.
We can go for a glutathione test, and we can go for a vitamin level estimation, vitamin B12 because of the back pain and all those things. And we can go for the vitamin B6, and we can also go for a dopamine level estimation in very high advanced cases. So these
Some
things are
inflammatory markers also Dr. Suchitra had mentioned, like
Yeah.
interleukin 6 and few others. So with time, I think this panel we have to only decide and make. That will be a better thing for the women. Vitamin D, B12, these all deficiencies are very common. Sir, what is your experience in clinical practice?
In clinical practice, we are not doing any cortisol in menopause because that is not at all required. The second thing, unless you are suspecting, yes, any stress level can increase the cortisol, but that doesn't make us to do the cortisol in all the patients, because when we are in a limited resources country, we have to, unless you really feel that it is really worthwhile doing some investigation, we should do it, number one. Number two, yes, madam has correctly told various metabolic parameters, out of which you have rightly pointed out regarding the vitamin D. Now the vitamin D is so rampant deficient, it is almost 80 to 90% of the general public. Yes. Whoever is sitting in this house.
I assume the reference range has not been set.
No, it has been said. So I will just make it clear. So for all practical purposes, any research purpose, if it is less than 20 nanogram per ml, we say that 25-hydroxy vitamin D. If it is less than 20 nanogram, we say deficient. Between 20 and 30 nanogram per ml, we say insufficient. The thing is that, yes, as madam has rightly pointed out, whether it is valid for us, yes, it is because throughout the world it is a now for all practical. But now tomorrow, if you want to do a research in your department, what cutoff you have to take so that you will proceed with this. So you need a uniform cutoff, at least to go to the compare with the results with somebody else. Otherwise, how can we compare this? So what I suggest is vitamin D estimation is so rampant. Even without doing a estimation, you supplement also, there is no harm. Because if 90% of the people are deficient, and regarding the various other parameters, including somebody has told about inflammatory markers. In real practice, we are not doing inflammatory like TNF-alpha, interleukin 6. See, obesity itself is a low-grade inflammation. In case of menopause, there is a redistribution, as madam has told, redistribution of fat from the gluteal region to the visceral fat. So when the visceral fat is one of the most insulin resistance. What do you mean by insulin resistance? Insulin resistance means insulin is normally at that place in the abdomen will inhibit normal lipolysis. lipolysis is conversion of proposal, biochemist, I should not say. Triglycerides converting into free fatty acids and glycerol. So insulin has got very unique action of inhibiting this hormone sensitive lipase. So insulin resistant cases, there is this lipolysis will not be inhibited and there occurs increased release of free fatty acids. This is causes a vicious cycle. Number one. Number two, the deposition of fat at the abdomen itself is a chronic inflammatory state. It itself will release chain of alpha, interleukin 6, interleukin 1 beta. It has its own myriad of actions and very actions throughout the body. So, if you are asking me what metabolic profile we do of course we do fasting plasma glucose, we do postprandial plasma glucose, we do of course lipid profile, we also do serum urea creatinine. If it is not required, we will do it, because otherwise you ask the patient again to come and do it, because if somebody has found to be the glycemic status is not good, then of course you require while treating, you require urea creatinine besides various other what madam has demonstrated. Thank you.
I just want to ask one question out of curiosity. That I read that even if FSH is fluctuating in perimenopausal and in menopausal state, it is rising. FSH is high. But ESH is not actually affected in that axis.
Yes.
But is there any correlation with perimenopausal time or menopause with the thyroid profile? If somebody is already hypothyroid or hypothyroid, have you ever encountered anything like that?
Actually, in fact, we have not encountered any situation like this. The alterations in the thyroid hormone profile, whether it is a T3, whether it is a T4 or a TSH, in the axis itself, suppose if there is an axis, the TSH is either suppressed or it is mortgaged. So normally what happens is that cortisol inhibits TSH. And central, if you see the pituitary and hypothalamus, normally cortisol inhibits TSH. But the level of cortisol that is required for the inhibition of TSH, like a Cushing syndrome, like you are giving exogenous steroids, then it will inhibit. But suppose if your mind increase in cortisol levels, normally the cortisol levels is very wide range. If you see the range of cortisol, serum cortisol, it is very wide range, normal range also. So it is in the normal physiological phenomenon, it is not affecting TSH and T3 and T4 that much. But in case of menopause, there occur certain changes in the binding globulins. For example, SHBG decreases, so free hormones might increase. That is one. It may affect to minimal effect on the PPG in the liver. Suppose if there is a the insulin resistance because of insulin resistance. So these are minor alterations which are in real sense, in clinical sense, we are not getting that much changes in the
cortisol level rises during perimenopausal and menopause.
Now that is also not very much validated. People think that it is because of stress levels, there occurs increase.
It is not related to stress, they are saying. It is related to the estradiol decrease, which is actually normally have an inhibitor effect on the cortisol releasing hormone. So that is actually affected and the cortisol level rises. That is what the study says. But it is not related to the stress. Actually.
Yes, actually the estradiol level and estradiol has got its receptors and there is hypothalamus pituitary region, except most importantly the GNRS neurons. And if you see that estradiol also has got effect on the pituitary also. But whether it alters the cortisol axis as such, I am a bit skeptical about it.
Completely, but
Yes.
they have seen a rise, but exactly why that rise happens.
Can I add something? I was really enjoying what sir was saying. So he has raised a very valid point. Cortisol is a very tricky customer. We have to understand that. Cortisol rises even say in extra-adrenal causes. It will rise say in certain cases even in part of a paraneoplastic syndrome. So we have to remember that the hypothalamo-pituitary adrenal axis is not the arrangement of that is not the only thing which raises cortisol. Yeah, so there are many possibilities. As such,
Excluding all these causes, it has been found that cortisol rises during
but that is
perimenopausal
more
and
of
menopause.
an incidental finding, like Cushing syndrome. Cushing syndrome itself will come with menstrual abnormalities, but that is not necessarily equating it with menopause.
Exactly.
Menopause is a totally different phenomenon altogether. Like you can have AMH. AMH is one hormone which indicates the length of ovarian reserve. Now many women who are nowhere near menopause have very low ovarian reserve and have abnormal AMH levels. Again, what Madam said regarding premature ovarian failure. The phenomenon mimics menopause, but it is not actual menopause.
hormonal milieu keeps on changing. And one more thing regarding SHBG, madam, for that it is very important. We do not usually estimate SHBG. What we can estimate is free testosterone level. Because we have to understand it is not the testosterone itself which is rising. It is the bioavailable testosterone which is rising. The free testosterone which is rising simply because it is unable to bind to its cognate globulin. That is why we estimate the free testosterone level. And nowadays, most of the private setups, at least not in the government setup like what sir said, there is a definite resource constraint. So we have to go for the generic parameters and say FSH, LH, estradiol, that's it. But in most of the private setups, they are having women's health. If there are people who are attached in private setups, they will say they have these packages. And these packages definitely include FSH, LH because there is a clear-cut reversal of the FSH-LH ratio. Along with that, they have estradiol, they have progesterone, and they have free testosterone, which is kind of a surrogate marker so far as SHBG levels are concerned. Apart from that, the generic women wellness, the glucose and all this, like glucose is actually a surrogate marker of insulin resistance, right? So if you come to think of it, one of the simplest surrogate markers is glucose itself. So that
to be specific, we go for different.
Yes, to be specific, we go for different tests provided we have the resources. But this much is sufficient.
Just one quick point to that. See, cortisol is only secreted from the adrenal gland only. It is not secreted anywhere from the body. There are various alterations. Suppose, for example, in paradistal neoplastic syndromes and all those things, what is happening is that there is increased secretion of ACTH, which again acts at the its receptors to cause that there is increase in the secretion of cortisol. Cortisol is only one place in the body to be secreted from the adrenal gland. There is no other place in the body where it can be seen. Yes, number one. Number two point, if any other syndrome is causing increase in cortisol, either it has to be increasing by increasing CRH or by it has increasing the ACTH. Number one point. Number two point, regarding the testosterone estimation, I think very good lab, very specialists are here. We have some discussion because what we are estimating testosterone is by immunoassays, and immunoassays has its own limitations, and free testosterone has to be estimated by the equilibrium dialysis, which is not so easily available. So various free indexes and calculation methods are there. But the thing is that in normal practice we are not doing any free testosterone because we are doing free androgen index based upon SHBG or we are doing a testosterone. So in really if you want to know, the cutoffs will differ. If you are using for example for a PCOS, the cutoff will be different. If you are using for any tumor, ovarian tumor, the testosterone levels will be different if you are using the different methods. So that is again the methodology is very important in these cases.
No sir, there are immunoassays for free testosterone also now. Just
No,
like
those are very highly available, ma'am. Thank you.
Sir, I agree with you. We are a resource deficient country. This is a purely rhetorical
Sir, since we are talking to you, let me ask a small question. That is, sir, what is the andropause?
Yes.
New concept is taking up, gearing up, and we have been talking since morning about menopause. Let's hear about
I am very
andropause.
surprised that andropause in women. Because andropause is actually what is happening is that normally just like a menopause, somebody who is born is going to die. That is as truth as anybody knows. Similarly, somebody entering into a menarche is destined to go for menopause. That is also very much certain. Of course, he or she lives longer enough. Suppose. Now, suppose who is a male who is having a normal hormones like testosterone and other hormones, it is not necessarily that all will develop into andropause. That's why they say that even a male of 70 years is as much fertile as he can be, as much fertile as a male of 20 years. So,
हम लोग सुने हैं आदमी और बूढ़े नहीं होते.
So I mean to say, yes, it happens. You if you ask me whether it happens in male or not, it happens. So the percentages are very low. Suppose if you take a 30 to 35 years, the percentage is only 8 to 10%. Now if you ask a 50 to 60 years old person, the percentage will be higher. If you ask a 70 to 80 years old person, the percentage is still higher. But it is not again 100% just like menopause. All who have menopause will to menopause, that is not going to happen. And now, the andropause in men, it is not just simply the decrease in the hormone. Many times it so happens, the hormone decrease and the symptoms, they don't correlate. He is having very good hormones, but he is not able to perform the sexual function is not able to perform. Hormones are low, but he is able to some extent he is able to pick up. That depends upon the androgen receptor sensitivity. So there are various other factors placing it.
Thank you, sir.
I'd like to add, andropause is more neurological rather than endocrinological.
What?
It is more neurological.
Andropause often has more neurological etiology to it rather than endocrinological.
So, since so many physiological changes are involved and so many psychological factors are also involved, I think best way to handle these things is to do yoga and some meditation. So that aligns our body with ourselves. So we'll hear a little bit about that from Madam, who is also a Raja Yogi.
The last question.
Thank you, madam, for the opportunity to talk something about the yoga and lifestyle. As madam has already told about the phases of life that enter into the Vanaprastha, that is, so if we consider in that regard, menopause or cessation of menstruation is so welcomed by our set of men when they stop menstruating. The irregularity of menstruation when goes through cessation of menstruations, they are so happy about their devotional lifestyle to be very independent of the menstrual disturbances. Apart from that, what we say consider in a positive aspect, what we consider as empty nest syndrome, it is also entering into the solitude of life. In the solitude of life, you go inside and inside, explore your own self. Till now, you have been dissipated yourself among your family members, among your in-laws, among your colleagues in the professional life. Now is a time to get into your solitude and explore your own self. So, in that regard, like whether it is associated with rise in cortisol, whether it is associated with a change in the HPA axis, whether it is associated with any other thing, definitely it is a affection of the neuropsychological hormonal system. Psychosomatic disorder is the cause of every disease that we encounter any stage of life, so also at menopause. So to correct that abnormality of the hypothalamo-pituitary adrenal ovarian uterine axis, not only for the polycystic ovarian disease that I ask them to go for a lifestyle modification, which all physicians will be advising. Beyond that, how pranayam of deep breathing, how it facilitates the blood circulation to the all chakras, including the your gonads, and that will increase the blood flow and increase menstruation. Similarly, it will also affect the abnormality of the menstrual cycle as well as other aspect of stress and pain, everything, if we go to the meditation state. Look, what is meditation exactly is, many people consider meditation in a very different steps, but what I feel right for me, and it is actually correct, go inside means exploring yourself. Yourself means yourself, who am I? That is the main question. When we explore ourselves as a soul I am, then you will be finding out that a less of thought is the positive thing that meditation should be concentrating upon. We are now bombarded with many informations and many thoughts are going on continuously in our brain. So how to reduce the number of thoughts is very important, and that as such can reduce our so much of hormonal swings or hormonal changes and mood swings and all. So in that regard, I can just say that yes, withdrawing is now the call of the hour, then to expand and go into every sphere that is available to us at the present time. To keep ourselves healthy is to withdraw from many things that we have been involved or done a lot in our past. So at this age, if we want a peaceful life and keep our family healthy, we first have to change and bring that lifestyle modification or change in our thought process, so that the more increasing stress in our children can be better addressed to. That the mother first practices this one, that will be going a long way. So in this Raj Yoga practice, we just try to concentrate upon our true self. Look, whatever knowledge we have acquired till now, there is no dearth of information, knowledge in anyone. The younger generation are the most informed and the most intelligent. Intellectually level mein, there is a very fast expansion and budding intellects are coming in the present generation. But intellectual stability is very important now. Call of the hour is stability. The fluctuation, everything that can be reduced by practice of any type of meditation, and being a practitioner of the Raj Yoga meditation, we say this is an inward journey. First of all, it is an inward journey. As we explore ourselves, you will really connect to yourself, and that will lead to an upward journey. Upward journey is to reach the Supreme Soul that up above. And when you have this inward journey, outward journey, get the joy of life, then you go for an outward journey of dissipating the positive vibration in you to everyone else. So that is about Raj Yoga, and I take this opportunity to wish you all a happy Raksha Bandhan, which is coming up tomorrow. And this is a time of bondage of love, security and protection of the Almighty God to you all souls, the Supreme Father extending His love and light upon all of you. Happy Raksha Bandhan to all of you. And I also thank the organizers for giving me this opportunity to talk. I learned about LMP, everything LMP, gynecologist thinks only last menstrual period. But I now knew that it is a lab medicine physicians, and ACC also is a good thing, that clinical chemist. So this is a very good opportunity to know many things. And being a gynecologist, menopause is only our topic, I thought, but many people talk much more than what I knew. So menopause has been in a very broad spectrum involvement of the clinicians, and this integrating understanding and knowledge is a very huge example of continuing medical education and the what is our medical education training system. So this is a very integrated CME. I enjoyed fully. Thank you very much. Congratulations for the CME. Thank you, madam.
Thank you, madam. So coming to end of this session, this very nicely all the panelists have enlightened us about different aspects of the topic, perimenopausal health and unaddressed envelope. Now we have some addresses, and I think in future also we will have some such sessions. Thank you, ma'am.
Thank you, Viyatprajna. Thank you all panelists. They came from a long way, reached in time, and discussion was very elaborative.
I got very unique panelist from Archikar Hospital.
Yes, and that also we came. So it's a God's blessing only.
Since yesterday, day before yesterday, I saw that one of our esteemed panelists from Arte, this thing, and yesterday while seeing various videos and various things, I am actually very disturbed since yesterday night. So if she is here, can she throw one or two lines on that? Just I want to know if she is willing.
We are as much in the dark as everyone else. It's a very unfortunate incident what has happened, and I personally knew her because I am part of the scientific committee, and 1 year ago she came to me for her thesis. She was a nice, quiet, introvert type of a lady. She was my own PG's roommate. It's a very traumatic time for all of us because we have become famous for all the wrong reasons, for no right reason whatsoever. Arjikar has always been very academic. I have been associated with this institute for the last 6 years. It is not my alma mater. My alma mater is NRS Medical College. And a few years back, NRS also underwent a similar type of upheaval, but not as shocking as this one, because that was by a stray patient party, and this incident was something which happened on duty inside. So we are trying to cope up with it. It's very difficult time for us. I could manage to come here. Our leaves are all cancelled because it's a Sunday. I could manage, and I don't know when this will end or how it will end. We are only hoping for justice. It's very difficult for us because we are right in the middle of the nightmare, and we have no idea when and how it is going to end. So let us see, and we are, only thing is that the entire world is with us. But I wish that people of Harvard and Oxford did not come to
think about.
We can
And
only
it will
hope.
save to our all doctor fraternity. So we pray God to keep her department soul. The morning we did the 2 minutes prayer also.
That's very nice. You are praying continuous.
So now it's a time to felicitate our panelists. They are in a hurry to go to the airport. So please felicitate.
Otherwise we'll miss our flight.
I invite our organizing chairperson, Professor Dr. Nirupama Devi ma'am, to kindly felicitate our panelists and our moderator. I also invite Dr. Suchitra Kumari ma'am, the General Secretary of ACCLMP Odisha chapter,